Hello, my name is Davide Capodano. I'm the editor-in-chief of EuroIntervention, and I'm here to discuss one of the debate, which is a new format that we launched this year around topics in interventional cardiology. And I'm glad to be here with the authors of such debate, Flavio Ribichini and Ignacio Amat-Santos, who discuss a very topical question, which is around TAVI and the management of coronary artery disease. So, of course, they accepted to take extreme positions, and we know that it's more nuanced than it seems, but I would like to know from Flavio first why he believes that when you have coronary artery disease in a patient undergoing TAVI, you do not have necessarily to touch coronary artery disease because you can do that later. Flavio.
Thank you for this question, Davide. Simply because the patient is coming to my observation because of another problem, which is the aortic stenosis. So I will try the problem, which is the aortic stenosis, and I will not try the coronary artery, which can be found just by chance in a patient who is asymptomatic for angina and has no acute coronary syndrome.
Okay, and Ignacio, your position was that when you have the disease there, before placing the valve, of course we are talking of stable CAD patients, by definition, you should treat prophylactically some of these lesions because then it will be more difficult to access the coronaries later.
Of course, we can be conservative in a stable coronary disease, but this is not just a stable coronary disease. It's a patient who is undergoing a stress, a high stress, as a kidney transplant, for example. To those patients, we treat coronary disease. Before a TAVI, we should also treat in advanced coronary disease, because otherwise, if there is a complication, which is rare but still occurs, this can cause a deeper ischemia in this heart, and can cause that we cannot recover the patient properly.
Okay, and Flavio, you listen to the arguments that are in our debate in the paper format. Do you want to have some counter-argument to what you have listened?
I think exactly the contrary, because thinking about the complications, I think you will face much more likelihood of having complications if you treat the coronary while you still have the aortic stenosis. In my experience, never a patient undergoing a TAVI has an acute complication because he has even a left main or a proximal LAD stenosis. The other way around, when you treat stenosis, which are found just by chance, first of all, you don't have a clinical indication to do that. And any complication you have in a patient with a low cardiac output because of aortic stenosis, it's like swimming in the mud. If you get rid of the aortic stenosis, you will be swimming in fresh water, and everything what you embolize or the contrast you give will be better let's say, tolerated by the patient, that hypotension, embolic problems to the brain, or contrast media to the kidney. Just take the stenosis out, and then your PCI will be, with the complication of additional work to engage the coronaries in some cases, a normal PCI.
Ignacio, so you have listened to these counter-arguments. The final words, it's yours.
So we know that more than half of the patients with STEMI or non-STEMI after TAVI are not treated, and we know that sometimes it's very difficult the reaccess. So this is important. Are we selecting a different device for a patient that would benefit from another device just to have a better access to the coronaries? I think that's a mistake. So treat it better and then select the best TAVI for that patient.
Okay, so you have listened to many arguments, pros and cons, and this is the spirit of the debate. So I invite all the readers of EuroIntervention to go to the journal and find this very interesting debate with a lot of literature, of course, and critical comments from both Flavio and Ignacio and their co-authors. I would like to thank them for joining us in this debate lively format, and thank you very much for watching this video.
Thank you.